Good evening, everyone. Coming from Dubai, here is Imran Abbas with Professor Lee, an exceptional and outstanding metabolic and bariatric surgeon who is also known for his decades worth research work with extraordinary results. It's great honor to interview such a prestigious figure. So as my viewers, so this interview series that we are following is about metabolic surgery in low BMI diabetic patients. As you know, we have started this interview series since 2021, and we started this series with MGB, OAGB, that was for 6 months. And if you remember, in that session, so we interview Professor Lee, and that was one of the best session. And then we continue interview series with safe sleep gastrectomy, then Roux-en-Y gastric bypass. And now we have started this metabolic surgery in low BMI. And in my opinion, this interview series is most important because nowadays, as you remember, as you know, all of you know, so this diabetes is real pandemic. So I will not take time, sir. Over to you, sir. So much thanks, sir. Please.
Okay, good evening, everyone. Thank you, Abbas, for the invitation. So I think IFSO and the APNDSS just launched a new guideline, specific mention about metabolic surgery, and now the criteria is going to low BMI. So I think it's a great thing. We can help more diabetes patients. Yes.
Sir, so much thanks. And also, as we know, so we have divided our question in 3 parts. So in first session, we will talk about patient selection. That is also very important. So which patient is candidate for this surgery? Because we are talking for low BMI diabetic patient. In second session, second part, we will talk about technical points. That is, so which type of surgery professor prefer? And in third part, so we will talk about his results. As we all know, and we follow his research work at the Globe, and really, in my opinion, this will be one of the best session. Sir, first pick up personally, I know because my viewers again want to know about your brief introduction and also your work when you start and your journey of bariatric surgery, especially metabolic surgery in low BMI patients.
Okay, so I will share my slide to introduce the indication.
Sir, we can see.
Okay, so the indication for low BMI, I think the definition, what mean about low BMI? I think it's relative our indication for bariatric surgery. So usually it's international, I think low BMI means 30 to 35. And not mentioned about the BMI 30, I think in international. But for the Asian, I think now specific, they mentioned 2.5 cut low. So it's around 27.5. But whether it can be considered in BMI 25 in Asia, I think this is the issue we need to clarify in the future. So about a low BMI, I think the background is ASIC make difference in BMI criteria. So if we look at this paper from UK, the blood bank, you can see the risk for diabetes in all ASIC. Diabetes incidence increase as long as the BMI increase, but it's different in scale. So if at the BMI 30 for white Caucasian people, in the low one, the equal risk can reflect in Asia. It's only around 24 in Chinese, and in South Asian, like Indian, they only 22. they have the same risk as the BMI study in white Caucasian. So we know is that the definition is different in different ethnic. So in Chinese, I think in most of the Asian population, you can see the distribution of diabetes patient in BMI located in 24, the highest peak. That is totally different from the Caucasian people. The peak BMI located in BMI 30. So you can see most of the Asian belongs to low BMI category. So in 25%, that is only quarter of the diabetes patient actually had a BMI more than 27. That is indicate for the diabetes surgery now. Not only diabetes, when we look at the other metabolic disease like hypertension, the situation is similar. So you look at the BMI 30, the lowest one is Caucasian. Then in the up one, you can see in the Asian, the incidence also is quite even at the similar BMI. So who can benefit or indicate it for now? I think when we talk about low BMI, actually, it's become not a good selection criteria because we all know the BMI not really reflect abdominal adiposity or central obesity. So usually the first criteria came to is a waist. So in Asia, we would like to choose patient with the waist more than 90 centimeter in male or 80, 85 in females. So it depends on the ethnic, and usually we needed to consider abdominal adiposity. The other is the insulin resistance. This can be reflected by HOMA or whether a patient has NASH. But to tell the truth, the fact is no matter what the BMI, everybody diabetes patient benefit from weight loss. 5 to 10% weight loss can alleviate most of the diabetes, even in very low BMI diabetes patient. So it's still the same. But of course, we need to know the most important thing is patient need to have a certain amount of beta cell function. Otherwise, no metabolic surgery can help this kind of patient, so-called type 1 diabetes. So I would like to introduce the ABCD, probably you heard about that. That is to consider a scoring system to consider the age, BMI, C-peptide, and duration of diabetes to make a score that we developed about 10 years ago. At the beginning, you can see we use the strict cutoff at the BMI 30 for obesity, C-peptide, half of the uppermost level, that is 2, and duration make cut point at 10 years. Then we had the first edition of ABCD score. But then you can see the remission rate is linear correlate with the ABCD score. The higher, the better. So in low ABCD score, the remission rate is quite low. But still, we can see some remission patient in the low ABCD score 1 to 2. So we modify into a second edition. So we have a better prediction. So now we had the other two famous score, I think Stammering score and the IMS score by the Cleveland Clinical. But we had to compare these two scores. I think ABCD score is the only one to recruit the C-peptide that reflect the beta cell. And it's more suitable in low BMI patients. The two other score is quite good, but most they developed from bariatric surgery, that is morbid obesity patient, not truly for the low BMI patient. So we compare the two different scores. When ABCD compare with the Diamond score, you can see this is the left side is Diamond score, the distribution of most of patients on the mid score. And the distribution AB score is more evenly. And the remission rate, both score, you can see the response rate is linear correlate with the scoring system. But you can see in the Dimery score, there is a sharp decrease from the 3 to 7 to this. Then the 3 high score is similar remission rate. So the differentiation power probably is not so ideal in this score. But if we look at the ABD score, the linear distribution is more linear, and the differentiation power, I think, is better. Another is compared with the IMS score. IMS had a 3 category. You can see most of the patients were located in a moderate score. And the completion remission rate, you can see there's a drop, severe drop from the 70% in moderate score to almost 0 in the severe score. So there's a big gap between the moderate score and the severe score. The differential power is not so ideal. But if you look at the ABCD score, this is a distribution, and this is a response rate. So the remission rate is more linear. I think it's have a more power to differentiate the diabetes patient. So, okay, so this is the indication now I use is in low BMI patient, we need more criteria. So they have better to measure abdominal adiposity and insulin resistance. And the ABCD score is an ideal tool to identify this patient.
Sir, excellent, excellent. And we need definite such a guidelines. So then we can go ahead and we can select our patients because the patient selection is most important in my opinion. Then we can predict. So, and as you have mentioned this A, B, C, D, that is interesting. And when we see the score will be high, result will be high, as I understand.
Yes, yes. The higher, the better.
Yeah, high will be better. And when score will be less, definite then. So we must talk with the patient and patient must know about this. And this was one point. And another point that you have highlighted, especially in South Asian and in Asia, BMI is not important. So that waist circumference is the most important because here central obesity is important, not so. So because maybe in future, then there will be no role of BMI. So that was not important. Just we will see the waist of a male patient 90 plus and female 85 plus. So that maybe so will be one of the criteria to select the patient.
Yes. And also a acceptable beta cell function reflected by C-peptide.
C-peptide, yeah, because C-peptide is very important. And one thing, sir, because in low BMI, another thing that is LADA. So are you rule out in all your patients this antibodies like GAD or islet cell antibody, or this is not routine?
No, because it's in Asia, the LADA is not really so high, 2 or 3%. So I only measure the C-peptide. If patients still have adequate C-peptide, I think it still help the patient, yes.
Sir, another thing, this C-peptide must be fasting stimulated or both?
I think both are okay. Either fasting or stimulated, they all have the important information, yes.
And what is your expectation? So in a good case, just imagine if C-peptide is 1.5 fasting C-peptide, and that postprandial or this stimulated C-peptide, how much it will be? Then you will ask, okay, now this beta cell reservoir is okay, and we must go. It must be double. But how much it must be postprandial? What is your expectation? A good case.
In good case is in your lab, you can see the lower level of C-peptide. So it should be at least twice of the lowest level of C-peptide is a good indication. If lower than the lower limit of C-peptide of your lab is not a good case, good patient. And another important, I think, is age of the patient. If it is an old patient, Probably we don't need so aggressive. But in Asia, we had many young onset diabetes, that is age before 40. I think we need to more aggressive to treat this group of patients because they are suffering high instance of renal insufficiency in their life. Yes.
Yeah.
They are
Sir,
more prone to have a complication. Yes.
Yeah, sir, another question. So regarding this microvascular complication of diabetes that routinely we see in diabetic patients, and we face nephropathy, retinopathy, or coronary artery disease. So is
Yes.
your routine to be like a MDT, multidisciplinary team, and your patient must be ruled out because maybe patient has no idea because he's suffering with nephropathy, or this is your routine because next maybe further you need data, and after 1 year, after 2 year, after 3 year, then you compare, oh, this was nephropathy, now improved. And also I will ask in question in third session, so is it compulsory to check up all of these patients by nephrologist or ophthalmologist, or no, selected patient you refer?
I think the diabetes surgery had better to do in those without an organ damage. If a patient already have organ damage, either retinopathy or renal or heart, maybe we should rethink about the indication of surgery. Because if they already have microvascular complication, it's not easy to reverse the microvascular complication. So we need to do the surgery before the organ damage.
No, sir, just imagine, so because we have routinely see patients, so there is a microalbuminuria and we
Yes.
see in urine, but still there is no indication for dialysis. And personally, I follow many of my patients, and this improved, and now they have no this
Yes.
microalbuminuria. This is my personal experience, and many patients I see. So maybe, so this is one of the treatment, and also we can prevent, especially this is a prevention of from dialysis.
Of course, I totally agree with you. Microalbuminemia is just I think is indicator of the initial of kidney palsy, but it's not contraindication. Many patients will have an improved of microalbuminemia. What I mean organ damage is the glomerular filtration rate less than 20. That is end-stage renal disease or chronic kidney disease stage 4. This is not a good indication for metabolic surgery. Yes.
Yeah, agree with you, sir. Sir, regarding this, as you have mentioned, so LADA is not common in our communities, and especially in Asia and South Asian patients.
Yes.
So which patient, when you see, you think, okay, I must go to rule out LADA. Have you specific indication for these patients? Young patient, maybe there is a family history is positive, low BMI, thin patient.
I think in adolescent or young adult, we need to think about, and if you want, you can check. If the patient is age is less than 30 or 20, I think it is probably is a good indication to check the LADA. Yes.
Sir, in our communities also, as you have mentioned, because as I remember when I was student of so medicine at that time, so what we learned, so if patient is so less than 30 years, there is more chance of type 1 diabetes. But nowadays we can see in also young patient, we have type 2 diabetes.
Yes.
So are you agree with me?
Yes, agree. Of course, the diabetes age is getting lower and lower. So we see many adolescent patients with diabetes. Yes.
And due to this, so we can also take, especially check C-peptide, and must rule out type 1. Maybe this young patient is also suffering with diabetes and will have some benefits from metabolic surgery.
Yes, yes, I agree. But I think this need to be proved by more data. Yes.
Yeah. Sir, in your ABCD, you have mentioned also age and duration of diabetes.
Yes.
So, because also C-peptide, we understand about this because my viewers personally, I learned a lot from this discussion. So, when you highlight age, what you mean age? When age is more than 40, because as you mentioned,
Yes.
more than 40, then take some points, but less than 40, that 40 was the borderline, as I understand.
Yes, because we look at our data, then do a multivariate analysis, and it come out 40 as this number. So the younger patient, the remission rate is higher than those with old age. And as I mentioned, young age also have more risk in diabetes complication. So, and the remission rate for metabolic surgery is better than old age. So I personally think in young age diabetes patient, we should more aggressive to treat. Yes.
But regarding duration of diabetes, just imagine a patient 60 years old or 55 years old with 20 years history of diabetes, but still C-peptide is 1.5.
Yes. So in this kind of patient, although the duration is long, but still have enough beta cell, sometimes this patient still have a BMI a little higher. This all is a good indication to do metabolic surgery. So I personally still would do in those with long diabetes duration, only if the C-peptide is enough accepted. Yes.
Sir, another thing that personally also I have faced in some patient was 100 kg, 95 kg, BMI was just 33, 34, but after diabetes, patient lose weight.
Yes.
So what happened? So in such a situation, now patient BMI is hardly 25, 26, 10 BMI dropped. So from 33, 34 to 25 within 1 year, but patient is using medication, everything according, but the diabetes is not controlled properly, but he's losing weight. Are you dealing with such a cases?
Yes, of course. The lifestyle cooperation of the patient is also very important. Yes. So sometimes we see the patient lose enough weight, but they still like the sugar drink or eating too much carbohydrate. Diabetes was still there. So it's possible.
No, my question, in such a case, can we, this patient is also candidate for surgery? Can we go for metabolic surgery in such a case? Just drop 10 BMI from 34, 35, because personally I had such a case till 25 now, but patient is using medications. So this HbA1c is 8 plus, 9 plus still. So definitely there is not good control of diabetes, no doubt. In such a case, can we, is this patient is candidate for surgery?
Yeah, sure. What we discussed, I think, is BMI below 32.5 or below 30.
Yeah.
If above 30 or 32.5, I think it's quite safe to do bariatric or metabolic surgery for their disease. Yes.
Okay, sir. Sir, in selection criteria, what is the role of HbA1c? Any role or no? Because it's come, because if you see, so diabetic patient HbA1c 7, and also we face such a case with BMI, another case HbA1c with 10. So is it any criteria, especially regarding HbA1c?
I think now there's no restricted criteria. You need to do surgery on HbA1c above a certain number because the A1C is only an indicator of control of diabetes. But what we really want is to reduce cardiovascular mortality. And there's more evidence to showing metabolic surgery do decrease cardiovascular mortality, even than many kind of medical treatment. So I personally don't don't think HbA1c is a necessary indication for surgery. If a patient use insulin, then A1C is around 7 or 7.5, and the patient don't want a medication, they want to cure their diabetes, and the BMI is enough, I still think they are good indicator for the surgery.
Sir, this is excellent. So, sir, another question regarding, so when we talk about patients, patient is diabetic patient. So using medication properly and also that healthy lifestyle, but long time he's using medications and also now he's using insulin and some units of insulin, but HbA1c is under control and less than 7, BMI is 30 plus, now more than 20 years patient, but he has been tired by using this insulin, but controlled diabetes. So he's using insulin, but controlled, not uncontrolled diabetes. So, can we go ahead for surgery in such a case?
Yes, the answer is definitely. I think this year the reason that there's a one randomized trial look at the BMI 27 to 32.5, a surgical versus the best medical treatment includes GLP-1. The study is from Singapore, and the 5-year result showing surgical win the medical treatment in this kind of BMI. So I think now we have the first randomized trial from Asia to prove the indication for low BMI. So don't worry, if the BMI is 27 to 32.5 with diabetes, surgery will do better treatment of this group of patients. So now we have a randomized trial, yes.
Sir, excellent, really. And in my opinion, so this is the time. So to go more aggressive for metabolic surgery, and in my opinion, it's need to collaborate with our colleagues, diabetologists, and also we can make such a collaboration with these guys. So then we can share our experience. So when patient with surgical intervention achieve these targets, so we must go ahead for the help of humanity, because now diabetes is real pandemic.
Yes, yes, yes.
Sir,
Totally agree.
Yeah, so much. Sir, now in this session, so I will try my best to highlight so your technical points that we are interesting to hear from your side. If patient is low BMI, which type of surgery you prefer in such a cases? If you have any video, if you have any presentation, please.
Okay, okay. Okay, so how to treat? I think my personal favorite is the mini or OAGB because we are inspired by Rubino. So the first paper to look at the low BMI, I think is from 2008. When we look at our patient and we first report is we notice in those with low BMI, use the OAGB, you still can have a quite good diabetes remission. Although the remission rate is less than those with the high BMI. So it's 78% versus 93%. So we have this data earlier as 2008, yes. Then in 2009, we compare at that time is VBG or bending. Bypass is win the procedure. Then for sleep, actually in 2010, we have done a clinical trial to look at the low BMI patient with sleep, because at that time, many things sleep can cure diabetes as well. So in this study, only 20 patients, the BMI is 25 to 35 low BMI patient. And the remission rate in 1 year is 50%. And the A1C can drop from 10.1 to 7.1. But important thing is you need to have a very good C-peptide. That is about 150% higher than the upper limit, so you can have a remission. If your C-peptide is less than about half of the upper limit, the remission is very low. So sleep is a effective treatment for diabetes, even in low BMI, but you definitely need a very good beta cell. So then we do a randomized trial to look at the mini-gastric bypass, and this is a shower, yes. So before we do this, the shower in 5-year famous STAMPEDE trial, he look at the blue eye and the sleep, and you all know the diabetes remission rate is similar, but in sleep, you need more medication to maintain. And as time go by, the recurrence is also higher in sleep. So then we do a randomized trial to compare the OAGB mini-gastric bypass versus sleep. So you can see the weight loss is not so make difference, but there's a way independent mechanism for diabetes remission. The remission rate is significantly higher in the OAGB comparing to sleep. At 5 years, the duration is still maintained, and you can see a difference in incretin effect. Both procedures increase the incretin effect. That means they all have some gut hormone response, but bypass always have a higher incretin effect than the sleep. So I think this is a reason for more durable diabetes remission in bypass patients, especially OAGB. In this study, we recruit 5 hospitals to look at the oral procedure and do a multivariate analysis. Of course, the remission rate is related to ABCD score, as I mentioned. In high ABCD score, almost all procedures have 80% remission rate. But in a low BMI patient, you can see the remission rate drop to less than 50 or 20%. So, but still you can see in sleep, the remission rate is lower. So the high still the black one, that is one of the most gastric bypass. So for diabetes patient, especially low BMI, I always consider the OAGB as my favorite treatment. And this is the case I want to show you is a BMI 27, very young, 20 years old, already married with a child and diabetes for 5 years. And you can see how poorly controlled diabetes and also have some microalbuminuria already. So in this kind of patient, if we don't treat aggressively, they will turn out to be end-stage renal disease very soon. But we do an OAGB for him. So 6 months, his BMI dropped from 27 to 22.7, but you can see the diabetes go away. So I think it's a very good treatment. If you select a good patient in low BMI, we still can have a good result. And in low BMI patient, we try to use our technique is to use reduced pulse. So in this kind of situation, we can see the procedure can be done in very minimal invasive. So for the liver retraction, we use straight needle, and you can see in those low BMI, the fatty liver still can be found in the patient. And as usual, the first cut from transvertebral side, we still can do the nice cut in the entrance. Then the gastric tube is created with a 36 G inside all the way to the EC junction. Because in low BMI patient, we want to make the invasive and very mild invasive surgery. And we use the Bougie, so a long narrow gastric tube was created. And through the umbilicus, I think the stable line axis is quite good, just as we do in the sleep. So all the way to the EC junction. We usually, because diabetes patients usually have very thick fat over EC junction. And if you want to create a narrow tube, you have better to dissection the EC junction to make sure your gastric tube is long narrowing. So after complete dissection, we can have complete divide. And we personally still use the 0-0 reinforcement because in our series, in our experience, this kind of reinforcement suture can decrease the bleeding or leakage instance. So in recent 4 years, we don't experience any major complication in this kind of technique. So it's quite safe. Then it's a bypass. We count all the small bowel because we want to avoid the malnutrition instance. And in the same time, we need to use a longer BPDM for diabetes control. So the most safe way is to measure the whole bowel and bypass around 30 to 40%. Then osmosis is controlled in 3 centimeters, not so wide and not so small. Then important is you make to use the bougie to make the full string directly go into the efferent loop. So if you don't have any obstruction at the efferent loop, the instance of bireflux will be very, very rare and fix the gastroenterostomy back to entrance. So the anastomosis is well protected by the stomach and will fix, and there's no rotation at the long term. So this is our technique we used. But of course, in Asia and in some part of the world, gastric cancer is still an issue. Especially, we really do pre-op, we see gastric cancer in China, in Japan, or in Korea. So the gastric bypass is not allowed in those countries because the risk of gastric cancer, they need to do yearly screen. So in this situation, we can consider is the sleeve plus, either sleeve DJB, but we think this procedure is a little complicated with a higher complication rate than OHGB. So now we favor is to do a bipartitional procedure or SASI procedure. So this is the case to showing our technique. We measure 5 centimeters from the entrance and do the sleeve as usual. In bipartition or SASI, you need around 4 to 5 centimeter entrance to make anastomosis. You cannot do like some surgeon doing sleeve, only leave a 2 centimeter entrance. There's a little bleeding at the upper part, so we wait. Then we back to complete the dissection. Then we pursue the sleeve gastrectomy. So you can see the entrance as around 4 to 5 centimeters, then all the way to the EC junction. And it's quite similar to the sleeve. So this is a complete division. Then we do a 0-0 suture as usual. We will bear all the stable line inside. Then osmosis is made on the stem on great capital side posterior way. We use the exactly technique we use in one osmosis gastric bypass, and we count the all small bowel. In SASI procedure, we bypass 60% of small bowel. We leave 40% common channel. And this is the similar technique we use in one osmosis gastric bypass. And we make sure the bougie come into the efferent loop. So we will anchoring the efferent loop to the proximal gastric tube to make sure the foot string is going to the efferent loop. That is to avoid the possible bireflux. So this is another technique that we use if the patient is hesitated in the risk of gastric cancer. Okay. Okay, so this is my technical part.
Sir, excellent, excellent, really, and also demonstration, especially that one anastomosis gastric bypass with the single port, that was really interesting, and especially your first stapler That was amazing. So how you rotate and adjust that part of stomach, and you did staple that first stapler. That was interesting. Sir, my question, because you have mentioned in OAGB, so you bypass about 40% of total small bowel, but in SASI, your common channel is 40%. It means you bypass 60% of total small bowel. So yes, I understand, because there is duodenum, and also food will also come from in SASI, from duodenum, and also some part of the food will go to direct ileum. The size of your enteroileostomy is about 3 centimeter. Am I correct?
Yes, yes.
Sir,
You are correct.
yeah. So now, what's the question? So if, because a definite small bowel, I don't think, there are rare cases small bowel length is less than 6 centimeter, very less. It is not routine, but routinely, if we see more than 90%, 95%, our cases, because personally I measure 100 of cases. So that is 600, 700 centimeter, 8. So when, just imagine in these cases, so if a small bowel length is 8 meter or 800 centimeter or 700, and 60% you bypass, so about 3 to 4 meter bypass. Have you faced any malnutrition in SASI in such a cases?
Not yet. Not yet. Because in original SASI technique, they recommend common channel is only 2 meter to 2.5 meter. So when we leave 40% distal, it's usually around 3 meter to 3.5, and very close to the SADI technique. So I don't think it as a risk in malnutrition. Yes.
So, sir, if you compare now, yes, you have mentioned in some cases there is risk of gastric carcinoma and need to follow up. In such a case, you prefer SASI. Now, as a, because you're leading person, leading surgeon, so if you compare both technique, there is no risk of gastric carcinoma. Oh, patient are same, there is no issue, and same BMI, no problem. Then which technique you will prefer in 2022? Now Professor Lee will prefer OAGB or SASI. There is no risk of gastric carcinoma.
OAGB.
Why?
I think in my lifetime, no surgery safety can win OAGB. For other procedure around, for sleep DJB, major complication rate in our experience is still around 3%. Yes. So it's for me, it's too high. And for the SASI, we still see complication from sleep leak or anastomosis leak. So the major complication rate still around 3 to 4%. But in OAGB, maybe we are quite familiar with that. We can safely do 0 complication rate. So that means a lot for us. The safety.
It's good. Sir, another thing, in your technique in OAGB, you imbricate all the gastric pouch, like this. And also this remnant side, also you do imbrication, or no need to do that?
No, for remnant side, unless there's a significant bleeding, otherwise I will leave the remnant side. I don't suture remnant side. Yes. Because
due to this less pressure of blood, because in the gastric tube there is left gastric artery, but in remnant side, that is the right gastric and gastric epiploid, maybe less. But personally, I face bleeding from remnant side, unfortunately.
Of course.
Yeah, I have faced 2 cases. One intra this gastric remnant pouch bleeding, and also bleeding from this. So yes, it may be happen, but this is not routine. But most probably bleeding is from gastric pouch. Due to this, you always imbricate your stapler line.
Yes, I routinely suture the the gastric tube side, but for remnant stomach, I only selected either the patient BMI or the patient have some breathing, yes, risk. I will suture, yes, in selective case.
Sir, in your experience, so if you see, and because definitely you know about this, because you follow your patients, this low BMI, which was the lowest BMI you did surgery as a metabolic surgery, and you did OAGB for the patient, that was 25, 22, 27, lowest BMI.
The lowest BMI I done, I think I had done 1 or 2 BMI 23, and some group 25. Because if the diabetes means a risk, especially as I mentioned in young diabetes, and the patient want diabetes treatment, BMI 23, if you can decrease to BMI 19 or 18, still diabetes can have a very good improvement. Yes.
And sir, in these these groups, that was the low BMI and really low BMI, 23 or 25. So your BP limb criteria was same. So 40% you must bypass in these cases, or no? You were little, so 150, 180, or no? You measure whole bowel length and bypass 40%.
I think in low BMI, when we're doing surgery, they must have a very strong indication for diabetes control. So we need to think the primary end is to control diabetes. Don't think about too much about malnutrition or something, because this can be easily treated. So, and we do many gastric cancer before. So in gastric cancer, we don't worry about total gastrectomy even in BMI 22, 20, because they will not lose too much weight. So I think if you have enough common channel and a good support, I think diabetes is still the primary end for us. So we need to try to elevate the diabetes first. Then we can deal with the possible complication. This is my philosophy. Otherwise, if you want a safe operation, then you probably don't need to do in low BMI diabetes patient.
Yeah, definite, sir. Sir, really great. And now in this session, in this third part, so we are interested to hear your results, because now I am talking with someone who is about working metabolic surgery or working a research work on metabolic surgery about 2 decades. So definitely it will be more interesting for myself and for my viewers. If you have any data, or if you want to show any slide, we are interesting. So your follow-up, your results, if any relapse of diabetes, please, sir.
Okay, good. So this is some of my thought now is, then what? We have to do metabolic surgery for low BMI patient. Then I think we now have data to showing the bariatric surgery improve the survival rate. The majority is in diabetes patient. But still we need to know diabetes patient had a higher post-operative mortality rate compared to those non-diabetes. So that means we still need carefully care of this diabetes patient, because they are still in higher risk than non-diabetes patient. So if you look at the BMI 35, we actually can decrease cardiovascular rate up to 50%, but to see the risk is still high. And a low BMI patient, probably not to 50%, but it still have 44%. But remember, the risk is still high. We need to continue care the patient. Then I think the more important information now we have is not all the procedure doing the same. So now I have a data to showing sleep gastrectomy is not really decrease much of the cardiovascular mortality compared to control group. And look at the chronic renal disease, there's only a little decrease. Comparing to the bypass procedure, you can see the sleep probably although the weight loss probably similar, but they don't have so much cardiovascular decrease effect. So I strongly believe in low BMI patient, we need to avoid sleeve gastrectomy for the treatment of diabetes. And this is the I mentioned the recently published randomized trial from Singapore. And this is the 27 to 32 indication, 5-year randomized control trial. And in this whole significance, they use GLP-1 as the medical treatment. So you can see in the medical treatment, they still have a HbA1c decrease quite dramatically, but surgical still outweighing of the medical in this study. And this is the remission of diabetes, and for the medical up to 5 years, surgical still have 42% of the complete remission. But in the medical arm, of course, they all need the medication. So this is, I think, the first level 1 evidence to support the low BMI or lower as to 27. So I think it's good evidence. So the conclusion for my thought is, in the past decades, metabolic surgery is becoming a accepted treatment for type 2 diabetes. But the better outcome should be achieved by precision patient selection, procedure choice, and outcome and measurement. This is my thought about the future. Thank you.
Sir, yes, definite. And this is overall general understanding when we do any type of gastrojejunostomy or gastroileostomy, definite, then there will be rise of GLP-1 because that nutrients, that undigested nutrient will touch L cell of terminal ileum and rise of GLP-1, then impact of GLP-1 on beta cell, and also that and inkeratines and role of glucagon, ghrelin hormone, and different. This is always it's discussable, and that Rubinio hypothesis, that is foregut and hindgut hypothesis, we definitely, and now we know about this DS, and also when we do when we will be more terminal, then definite long time results of remission of diabetes. So what is my question? Your patients, your experience, what is your experience? What is your data? Which percentage of your patients are suffering with relapse of diabetes? Have you any data?
Yes, yes. I will showing my data, yes. Okay. So no, I didn't bring to this computer, but the recurrence rate, the first thing is of course related to ABCD score. And the second is 5-year recurrence rate for our data is in sleep, the recurrence diabetes around 30 to 40%. But for OAGB is only 15%. So the recurrence rate is much higher in sleeve gastrectomy, even they have a remission at first year. Yes.
Sir, maybe it is due to weight regain. So just you think and know another factor. So what we must do for better results?
I think there's a way independent effect in bypass procedure. And the problem is the insulin resistance is not decreased so significant in sleep. And in bypass procedure, still they have some effect in duodenal exclusion. That is my personal thing, yes. But we don't know, we need more research on this project, yes.
Yani, sir, it means you think about this, that foregut hypothesis or foregut theory is working. So when we yes, must bypass that proximal small bowel, then yes, we will take better, because nowadays, so these endoscopic surgeons, they are doing this barrier and some endo barriers, and they are talking about this. They are also talking about the mucosa of duodenum and like these things. So many things we hear about this. So you agree with this? So bypass of this proximal bowel is helpful?
I think is the BP limb because the food is exclusion from the proximal gut. So the bile acid will be reabsorbed into the blood. So I think higher bile acid in the blood means a lot. This is my learning from the previous animal experience and also the clinical data. So I think the bile acid in the blood means a lot. And the bile acid is coming from the BP limb. So that's why I think we need to have a BP limb. And the longer, the better. Yes.
So, sir, you means because in metabolic impact of bariatric surgery, we have now microbiota role. That is also nowadays, and also change of microbiota, because when we do any type of gastroduodenostomy or gastrojejunostomy or gastroileostomy, our microbiota changed. Now we face aerobic microbiota, and then the role of microbiota, and also this rise of bile acids that we see with the increase of BP limb, that again the receptors and impact on liver and many things. So we're discussing and still in research phase.
I don't believe biota. Yes, I think it's a result of we manipulate the intestine. It's not the cause. Yes.
Okay, sir. And again, so there is also, we are discussing now the role of mitochondria and change of mitochondria, especially sorry, before metabolic surgery and after. Because if we see mitochondria before metabolic surgery, there is a fat in mitochondria, and role of mitochondria if we see after metabolic surgery. So this is also nowadays a research work nowadays, and they are doing, maybe this impact of mitochondria is more dominant. I have no idea, just I am asking a question, because in literature now many publications, so their role of microbiota, role of mitochondria and different things, and bile. So, and but in according to your opinion, bile acid is more dominant.
Yes, I believe the bile acid is more dominant, but the effect of bile acid is in the liver enzyme, FX, yes.
Yes.
And also probably through GLP-1. So that is why GLP-1 is so successful in the recent medication. And we also have a tropizide. There's a 2 combined or 3 combined gut hormone new drug will coming out. So I think definitely the gut hormone is play a dominant role in medical treatment. But in molecular mechanism, I think bile acid still is the key molecule. Yes.
Sir,
and for other mechanism, I'm not sure, but time will tell. Time will tell.
yeah, but still I think so maybe need more research work, and still this
Yes.
metabolic surgery has a long and hard journey to mature. So which changes occurs in this GI tract, that so many of this metabolic syndrome and like hypertension, like diabetes, and also one of the effective surgical treatment.
Yes, the good news is we know it's work, but probably not really know how it's work. We need more research on it. Yes.
Sure, sir. Sure, sir. So much thanks, really, because I think now in midnight in Taiwan,
Yes.
and 12 across, and really it's great honor, sir. Always you're sportive, always you are encouraging, and we need your definite your sport. And because you are leading person at the globe, especially for metabolic surgery, and you are someone who guides, so give us these guidelines. And as you have mentioned earlier, so BMI is not important in metabolic surgery. The role
Yes.
of waist is more important. And hopefully very soon a new guidelines will come and it will be easy for a surgeon to select the patient.
Okay. We will
Sir,
try.
yeah, definite, sir. Sir, so much thanks. And personally,
Okay.
I have learned a lot, especially that ABCD, that was really interesting. And now it will be very easy for us to predict and select the patient and predict the result of diabetes remission after this metabolic surgery. Sir, so much thanks, sir. We have, because at this channel, and we have a YouTube channel as well, and also Global Laparoscopy and Robotics. So we have also some newcomers. So your message for someone who is just now going to start metabolic surgery.
I think if you are newcomer to doing this, should be very careful. Yes, and because you need to master the bariatric surgery first. Then you understand the metabolic surgery, and you have experience in diabetes care. Then you can go inside. So probably not at the beginning. You're doing metabolic surgery for low BMI patient. You would rather do standard bariatric surgery practice, then accumulate experience, and also in cooperation with your endocrinologist colleague to more understand the diabetes treatment, then you can start to do this kind of procedure. Technically, it's not so difficult because in low BMI, all the procedure looks like not so difficult. But I think post-operative care management, and you need to match the expect from patient. This all it need experience and knowledge. Yes. This is my work.
Sir, so much thanks, really, and my viewers, so much thanks. So these are sessions is due to your interest. If you have any question from Professor, you can ask in the comments, and Professor will respond. And we will continue our this series of metabolic surgery in low BMI, and next Tuesday at 10 p.m. Dubai time, because now 7 p.m. was due to Professor and the timing of Professor, but routinely our interview session is at 10 p.m. Dubai time. And next week, we will be with another expert of metabolic surgery, Professor Karim Sabri from Egypt. And definitely, we will talk about metabolic surgery in low BMI. So much thanks, my viewers, and I hope next week, Tuesday, 10 p.m. So we will talk about, again, we will talk about this metabolic surgery. Again, sir, so much thanks, and have a nice time, sir.
Okay, thank you, Baba. Thank you, everyone. Bye-bye. Good night.